Welcome doctors. In this video I am discussing about Hanoscolin purpura video station HSP. So Hanoscolin purpura, that is an immunoglobulin A vasculitis. There is small vessel vasculitis secondary to immunoglobulin A immunocomplex depositions. Elevated immunoglobulin A in the blood targets cells, endothelial cells. And there is vasculitis in the children, frequent follows of upper respiratory infections. Okay, there is an upper respiratory infection, there is an immunoglobulin A deposition occur in the vasculitis vessels. The clinical features we know, the age is 3 to 10 years. Classical triad is there is palpable purpura. Remember, the rash is actually maculopapular, palpable purpura. Okay. Then arthritis, arthralgia, abdominal pain, these are the features. We look the pictures of this man. There is nausea, vomiting, nephritis, abdominal pain, occult blood in the stool. That is hematuria present, arthritis, arthralgia, palpable purpura. The rash, look at the leg, maculopapular rashes, palpable purpura. So mnemonic of HSP is hypertension, hematuria, glomerulonephritis. There is small children seizure, treatment is steroid, palpable purpura, proteinuria present, arthritis, abdominal pain, immunoglobulin A vasculitis, and immunoglobulin A nephropathy. HSP DD, what are the we keep? HSP, ITP, NAI, drug reactions, COVID, leukemia, sepsis, DIC, and PIMS we can keep. History, the first onset course in duration, and anything make it better, anything make it worse. The rashes distribution is very important, we know. The rashes is the lower limb part of their distribution, abdominal any pain and its severity, blood stool, its color and site, any joint pain, arthritis and their number, frothy urine and its color and amount, anyone measure his blood pressures, pain and redness in the private in male. So orchitis, we male present, and headache, seizure and any abnormal gait. At DD exclusion we ask like the family registered to social service, then any history of drug intake, any trauma, any neck stiffness, then these are the we can ask, any sick contact, family similar condition, first time or recurrent occur, these are that. So again the history we ask, concept of the rash and its distributions, abdominal pain and its severity, blood in the stool and its color and its site, joint pain, arthritis and their number, frothy urine and its color and amount, anyone measure his blood pressure, pain and redness in the private in male, headache, seizures and any abnormal gait. Examination, you do the ABC vitals, especially the blood pressure, examination of the rash itself with glass test, non-blanchable, neurological examination, MSK examinations, abdominal examination and lymph node to exclude the malignancy. Again the examination ABC vitals, especially the blood pressure, examination of the rash itself with glass test, non-blanchable, neurological examination, MSK examination, abdominal examination and lymph node to exclude the malignancy. Investigation, we do the blood pressure, urine dipstick, if proteinuria, send urine for early morning protein creatinine ratio, if hematuria, urine microscopy, if urinalysis abnormal or diagnostic uncertain, full blood count plus blood film, urine electrolyte, albumin, if fever, blood culture and ASOT, coagulation and throat swab. Management is indication for admission. First of all, so investigation, blood pressure, urine dipstick test because of proteinuria, we do the full blood count, ASO titer, urine electrolyte, the coagulation profile, these are blood cultures. Management actually, we according to features, admission needed or not. Indication for admissions are orchitis, moderate to severe abdominal pain, arthritis involving more than 2 joint, proteinuria, GI bleeding, inability to ambulate. Joint pain, we are giving NSAID like ibuprofen. Abdominal pain, if severe and persists, exclude pancreatitis, intussusceptions or spontaneous bowel perforations, prednisolone for 2 weeks we give. So treatment are we are giving NSAID, ibuprofen, non-steroidal anti-inflammatory drugs and prednisolone for 2 weeks. Follow up. Uncomplicated HSP, urine analysis less than or equal to 1 plus blood and protein and normal blood pressures, no hospital follow-up required but GP follow-up within 1 to 2 weeks. Monthly blood pressure for 6 months and weekly urine dipstick at home until urine is clear. HSP with hematuria or proteinuria more than 1 plus and normal renal function as above plus routine follow-up in children's OPD. So these are we can do. What is the indication of refer to the nephrology? Refer to the nephrology or urinalysis, blood or early morning protein more than 1 plus after 6 months, macroscopic hematuria or heavy proteinuria at presentations, hypertension, see hypertension guideline. Okay, so indication nephrology or urinalysis, blood and early morning protein more than 1 after 6 months, macroscopic hematuria or heavy proteinuria at presentations. Then hypertensions, significant proteinuria, early morning urine, protein creatinine ratio more than 100 gram per millimole or 3 plus proteinuria for 3 days and impaired renal functions. So significant macroscopic hematuria, proteinuria presentations, early morning protein ratio more than 1 after 6 months, there is hypertension, significant proteinuria, early morning protein and creatine ratio more than 100 gram per millimole, impaired renal functions. These are. Refer to rheumatology if there is atypical rapidly evolving rash. Advice and red flags may fluctuate for several months, but recurrence is rare. Okay, the advice of the red flag fluctuates several months, recurrence rate is rare, very rare risk of renal failure 1 to 3%. Seek medical advice if child develop headache, rectal bleeding, and severe abdominal pain. So, we'll give the advice headache, abdominal pain, rectal bleeding. So remember, there is a very risk of renal failure 1 to 3%, and ITP recurrence rate 20%. ITP is 20% recurrence rate. So this is the HSP. Thank you.